Last week, when we talked about acute respiratory failure and ARDS, what was the only treatment again? For acute respiratory failure and ARDS, what's the only treatment for that? Oxygen therapy, okay? And particularly for ARDS, because what's do ARDS patients respond to oxygen therapy? What do we call that condition again? Refractory hypoxemia, correct? So therefore, the only way we can promote gas exchange in ARDS patients is to intubate them and put them on a ventilator. So we're gonna have to push the air under positive pressure into the lungs to push out the water out of the alveoli. However, like I said, after the water is pushed out and the ventilator stops giving a breath, what will happen to that water? It go right back in, okay? Because again, the capillaries wrapping each alveolus are leaking, okay? So during this period of capillary leak syndrome, the condition will continue. So we need to keep the patient alive long enough in order to hopefully keep them, make sure gas exchange happens until the capillary leak syndrome resolves, because it will resolve eventually. We just don't know when and how long. Patient just needs to stay alive until that happens. Are we clear? Okay. So here are our responsibilities now. So first, we need an artificial airway. You cannot put a patient on a ventilator with just a mask. You need an artificial airway. And you need to seal off the patient's trachea. So this is the placement. Please observe where the trachea, where the endotracheal tube is. We prefer the endotracheal tube because it's the fastest we can insert over a nasotracheal, because a nasotracheal means it's a smaller tube, because we can't put a big tube into the nostril. So an endotracheal tube is going to provide us with a good size plastic airway. However, if the patient requires endotracheal intubation and therefore mechanical ventilation for longer than 2 weeks, we will have to give the patient a tracheostomy. Are we clear? Because there's more benefits to a trach long-term compared to endotracheal tube. Because when you have an endotracheal tube, can this patient eat? Can they chew and swallow? No. So therefore, is it comfortable also? So to keep the patient comfortable, therefore, do we need to sedate that patient? Yes. So therefore, that will delay healing. It will mean if you sedate somebody, that means they're bedbound. We can't get them out of bed. They can't communicate. They can't interact. So therefore, they'll have pressure ulcers, DVTs, lots of complications over a long-term endotracheal intubation. So we will switch to a trach if the patient requires long-term mechanical ventilation, okay? But let's finish the endotracheal tube first. So here are the parts. So you've got the shaft here, and then there's a cuff at the end. So this is a balloon. Think of it as like a Foley. Now the balloon will serve two purposes. No, it's not a balloon, it's a cuff, okay, which is like a balloon. We call it a cuff. We inflate the cuff for two reasons. One, look at the placement of the tube. Since the tube is hanging over between the esophagus and the trachea, and this is what do you call this structure? This one? What is this piece of muscle here? That's the epiglottis. So this one will move forward when we swallow. So when you swallow anything, food, water, or spit, this epiglottis will move, covering the trachea so you don't choke on whatever you're eating. Can this do that when the patient has an endotracheal tube? No. So therefore, can this patient clear the secretions? No. No. So that muscle becomes useless. So therefore, we need to inflate the cuff in order to seal the airway. Okay, so that's one purpose, to prevent aspiration. A second reason is that means if this endotracheal tube is connected to a ventilator, so that means air is now pushed into our lungs forcefully under positive pressure. Is that how we're supposed to breathe? No, we're supposed to be negative pressure ventilators. So how we breathe is our diaphragm contracts downwards, and then the air is sucked in from the atmosphere passively. So we don't push the air in. The air is sucked in like a vacuum. That's how we normally breathe. Is that happening here? No. The air this time will have to be pushed under positive pressure. So the ventilator will push the air. Will there be pressure, therefore? Will there be resistance from the lungs? Yes, the lungs will pose resistance because you're pushing the air forcefully. So as the air enters the tube, will some of it leak around the tube? Right here. So as the air enters the lungs via the endotracheal tube, will some of the air, because there's resistance posed by two lungs, will some of the air leak out around on the sides?
Yes.
That means, will we deliver the accurate volume of air each time? No. So that's another reason why we inflate the cup. All right. So what are the two reasons again of inflating the cup? Prevent aspiration and to prevent leaking of air. Okay, we want all air during inspiration and exhalation to go in and out through the tube only. We cannot have them leaking around the sides. However, the trachea is this living tissue.
Yes.
What will happen if you overinflate the cuff? It will cause ischemia, correct? All right. So the cuff has to be inflated to a certain pressure, which is between 21 and 22 millimeters of mercury. No, sorry, 21 and 25 millimeters of mercury, or 20 to 30 centimeters of water. All right. Okay, so 20 to 30 centimeters of water, or 21 to 25 millimeters of mercury pressure. Okay, so we'll look at the tube shortly. Now, first of all, we do not intubate. The persons who can intubate are respiratory therapists. Any physician can intubate, nurse practitioner, physician assistant, but not nurses. Are we clear? NPs, NPs, acute care NPs, critical care NPs can intubate, obviously. As far as the item on the finals blueprint where it says indications for endotracheal intubation, meaning who are going to be intubated, here are the answers in this paragraph. It's not a table, it's just mentioned in the paragraph. So here, patients who cannot maintain an airway on their own, patients who are comatose or upper airway obstruction, patients needing mechanical ventilation, and suctioning secretions from the pulmonary tree. The procedure, yes, sir. Our textbooks say it's sterile. Respiratory therapist textbooks will tell a different story, okay? Which they actually correct. I mean, how is this sterile, right? Is the respiratory tract sterile? No. Okay, so look at the end of the tube and then imagine the bronchial tree. So we have the trachea, which divides into the right and left brainstem bronchi, correct? Okay, so think of it as your legs, and then the carina is the crotch. Can you picture that? You know, the bronchial tree and then the right end. So it's like our legs, right? So that the torso and then the crotch would be the carina. The carina is where the trachea becomes the right and left brainstem bronchi. That's where we want the tip of the tube to be. Why? Why do we want it there? So when the ventilator gives the tidal volume is the volume of air given with each breath. When we give the tidal volume, do you want it to go to one or both lungs? So for it to go into both lungs, where should this tip be located? Above the carina. All right. So it should be 2 centimeters above the carina. That's the placement of your endotracheal tube. So let's imagine the scenario. So let's say clergy is our patient. She overdosed on something. Now she's unconscious. She's not breathing normally. So her breaths are down to 6 breaths per minute. So do we intubate her? Yes. So we intubate by, however, she's still semi-conscious. So when we put in a stainless steel laryngoscope into her mouth and down her throat, will she fight it? Yes, she's still semi-conscious, so she's confused, okay, not getting enough air, she's confused. She's gonna fight anybody who's trying to do this to her because she doesn't know whether we're helping her or killing her at that moment. So the confusion will cause her to fight. Now, to prevent that from happening, from anyone losing their teeth or getting kicked in the balls, now we have to sedate her. The sequence of intubation is now called a rapid sequence intubation. So we will sedate her using a short-acting muscle relaxant called rocuronium, or but the most popular is rocuronium. So we need an IV, of course. We give it to her in a few seconds, and then she's out. 3-4 seconds, she's gonna be unconscious. She's going to be compliant now because she can't do anything. She's out, and then we can peacefully insert the laryngoscope, shoot the endotracheal tube into there, and then remove the laryngoscope, inflate the cuff, and there we go. Right? Nobody got hurt. So how do we know that the endotracheal tube is 2 centimeters above the carina? Can we see it? Okay, so we need an X-ray first. So chest X-ray will be called. However, does that mean she will have to wait 10-15 minutes before she gets breaths? No. We will have to inflate the cuff, making sure the cuff inflation is within 21 to 25 millimeters of mercury or 20 to 30 centimeters of water pressure. And then we start bagging the patient. So manually bagging the patient, or if we want, we can even put her on a ventilator at that point. And then the chest X-ray should be available up on the floor in 10 to 15 minutes, and then we'll confirm the placement. If it's not 2 centimeters above the carina, then the doctor or the respiratory therapist will adjust it. Okay, so the X-ray report will come with recommendations saying, okay, push the endotracheal tube how many centimeters more, or pull it out how many centimeters more. Are we clear? Okay, so that's the.
At this point, do they do a second chest X-ray or just?
No, because the radiologist will already make recommendations like, oh, okay, it's a little off. Okay, so either push it or pull it out. Again, inflation of the cuff does what? 2 things. Prevents air from leaking around, and also to prevent aspiration. Very good. And there's the X-ray. Now, another way, because again, do we have 10 to 15 minutes before we start giving her breaths? No, we have to start giving her breaths right away. So another way of checking placement is checking the end-tidal CO2 level. What is this? This is done through a capnometer. You know what a pulse oximeter is? Okay, so it's like a pulse oximeter. However, it's not put on a finger. It's put at the tip of the tube. So the sensor will be placed at the end of the tube right here. And then the capnometer will read the CO2 levels as the patient exhales. So as clergy exhales, as long as it's, what's the normal CO2 range? 35 to 45, correct?
Yeah.
So if it's 35 or higher, then it must be, the tube must be where?
The right place.
It must be in the trachea, right? Because can the tube go into the esophagus instead?
Yeah.
Yes, in which case, will we see a high or normal CO2 level?
No.
No, it'll be low, okay? What's another way to check placement? So as you're giving a breath, what will rise? The
Chest.
stomach or the chest?
Chest.
The chest should rise. So obviously, if the stomach is going up and down, where is the tube? It's in the esophagus. Another way is, can you hear lung sounds if it's in the chest, if it's in the trachea?
Yes.
Yes. So those are obviously common sense ways to check placement. Okay. So a combination, but what's the most accurate way of checking placement? And end-tidal CO2. Okay. So it's not one, it's two. Okay. There should be X-ray, which shows it's 2 centimeters above the carina, and the end-tidal CO2 level, which will show us what?
CO2 level.
Okay, a low, a normal or high CO2 level. Are we clear? Okay, it can't be one or the other. It's both, because even though the X-ray shows it's 2 centimeters above the carina, can the X-ray show whether or not it's in the esophagus? Because the chest X-ray is taken anteriorly. So can the chest X-ray tell where the tube exactly is? Because remember, the trachea and the esophagus are parallel.
Yes.
And you take an anterior view, can you see where it is?
No.
No, you can check it if you're on the lateral view, but this is an anterior view X-ray, so you can't tell. So it has to be two, all right? So end-tidal CO2 level and chest X-ray. Okay, very good. Here are the, the numbers are a little different here, so we'll follow your textbook. I was following my institution's numbers. So your textbook says 20 and 25 millimeters of mercury, and then 24 to 30 centimeters of water. Are we clear?
Yes.
What will happen if the pressure is under 20? Leaking and aspiration. Very good. What will happen if it's too high?
You state the sin, the
tracheal ischemia. Okay, all right. Here, so it'll cause tracheal bleeding, ischemia, or necrosis. Okay, and then low pressure will cause aspiration. Okay. Now, please take note that will secretions continue to be produced as long as that tube is in there?
Yes.
Yes, just like when you put a pen, a pencil, or a lollipop in your mouth, what will happen? Secretions will be stimulated, correct? So therefore, no different here. Although the tube doesn't taste good, it will otherwise still stimulate secretions. So therefore, can this patient clear secretions that are going in here in this place right here? Yes or no? No. Correct. Now, can you suction this area though? This area, we can suction the tube. We can put a catheter inside the tube and suction secretions that are in the tube. Can you suction this area right here, which is around the tube? Let me finish. Can you suction this area? So let's say your suggestion is to put a catheter into the mouth. How far will it go? Exactly your question. Can it reach here? So let's say you put the catheter here into the mouth. Will it turn sharply and then go in here?
No.
So therefore, can you suction these secretions right here?
No.
Impossible. To suction that area, you need a special tracheostomy tube, one that's called a high-low evac tube. The high-low evac tube will have 3 lumens. This one has 2. One, this is the first lumen. The second lumen is for the cuff. So there'll be a pilot balloon coming out here. A high-low evac tube will have a 3rd lumen. It'll have a second line, which will be attached to a suction, and then it will suction this area right here. Understand? Any question? All right. As I mentioned earlier, if the patient will need this artificial airway for more than 14 days, 2 weeks, what do we do? No, they already are intubated and then they need the airway longer than 2 weeks. So we will switch to a tracheostomy. Very good. Right. So here are the advantages again over ET, of a tracheostomy over an ET. So with tracheostomy, the patient can do a lot more. Okay, they can swallow, they can chew, they can eat, they can be out of bed, okay, all while still having our artificial airway through the neck and still being on a ventilator. Clear? So faster healing and they can even communicate. All right? Because we don't have to sedate them anymore. And of course, we're not discussing whether or not the tracheostomy will be permanent or temporary. It all depends on the patient's condition. Clear? So here are your responsibilities after the patient receives an intubation. Like we said, until we get the X-ray and the end-tidal CO2 levels, check the symmetry of the chest expansion, meaning we're looking at other ways to confirm placement. Okay. Cuff pressure is checked every 6 to 8 hours. How do we do that? We insert a manometer to the pilot balloon. Show you a picture. So this is the manometer. So you'll see the manometer in a little tote bag hanging on the ventilator. There's always one on it required. So what do? This is the pilot balloon I was talking about. So this is the cuff, which is inside the patient's neck. And this is the end of the tube, right? So here's the pilot balloon. It's hanging out on the side at the mouth. This is the pilot balloon. If the pilot balloon is inflated, that means the cuff is inflated. If the pilot balloon is flat, that means the cuff is deflated. That's all it can do though. You cannot tell how much pressure is in the cuff. By the way, we fill this with air, not water. Why? If it pops, it's gonna cause aspiration. Make sense? Plus we don't really need to put it, inflate it with water. I mean, why? You know, we inflate it with air. So the pilot balloon, as soon as you remove this syringe here, you attach it to the manometer. The manometer is nothing more than a glorified tire pressure gauge indicator. You know, when you inflate your tires, there's a gauge you attach, right? Telling you how much pressure is in the tires. Do you know what I'm talking about? Okay, so that's all it is. So when you attach the pilot balloon to it, press the trigger, it will read the pressure. And what should the pressure be to be normal and safe? Again, let's follow your textbook. Textbook says.
21 to 25. For what is 24 to 30?
Okay, so for your textbook, it says 20 to 25 millimeters of mercury or 24 to 30 centimeters of water. Sorry about the numbers I quoted you earlier was from my facility. It differs from facility to facility or textbook to textbook. So you check pressure. Why? Why do I have to check it? I thought we already inflated it and checked the pressure.
If it not deflate or if it not.
Yes, same thing. Do your tires lose air pressure?
Yeah.
Yes, especially in winter. So no different from this. So the cup pressure can change, can deflate over time. So you need to check inflation pressure to make sure it's still within the safe range. Now the ventilator, of course, is it the same as our respiratory tract? I mean, does the ventilator provide a nose? Why do we have a nose? What's the purpose of our nose?
Inhale.
So what happens as air passes through your nose? And there's hair there, right? There's mucus in your nose. There's hair. What does it do when the air before it reaches the lungs?
Yes,
What else does it do? Humidifies the air, correct?
Yeah.
Humidifies it and warms the air, correct? As it passes through. Is there a nose on a ventilator?
No,
So therefore, do we need to humidify
yes,
and warm the air as it enters the patient? Yes, we need to do that. So make sure there's water humidifier in the ventilator. So there should be a visible mist. Now, because there's warmth and moisture, what do you always get with that combination? Warmth and moisture, just like in the weather. So what will always happen?
you said like,
What will form? If you have moisture, mist, and warmth, what do you get? Rain, right? You get condensation. So will there be condensation in the ventilator tubing?
yes,
Okay. Tubing, in case you don't know what a tubing looks like. So here's the circuit tubing for your ventilators. So you've seen these, correct? The blue, this one? Hey, you've seen these tubes, right? Okay, so these are the ventilator circuit tubings. Okay, so will moisture gather in the tubing? Yes, because we humidify and warm the air as it exits the ventilator. Sorry?
No, I was looking at the price of it.
Are you planning to buy some? What for? Jump rope? We put the correct FYO2. This will all be ordered by the provider. Okay, and then we'll talk about the ventilator settings shortly. Secure the tube to the patient's face. We no longer use tape because what will tape do when the patient drools and sweats? It will no longer stick. So here are ventilator commercial tube holders for the vent. So this is what it looks like. This will be put around the face. Obviously, this part here is in the back of the patient's head, and this will be on the patient's face. Okay, so these two pads will be on the patient's face, and the tube will be secured here. All right. As you can see, it's Velcro, right? So is there any tape on the patient's face at all? No, only straps secured by Velcros. And as long as the patient is sedated, this should stay in place. Can the patient pull this off? Yes, so make sure your patient is properly sedated, or if they're resistant to sedation, make sure they are restrained, right? So we restrain, it's a valid indication for restraint because we need to ventilate the patient and they are interfering with the therapy. Okay. So is this patient bedbound? Do we need to turn them every 2? Since they're not getting out of bed, are they at risk for DVTs? Do we provide DVT prophylaxis? Okay. Can these patients get up and brush their teeth?
No,
So how do we perform oral care?
you have to use
We
the.
have, okay, so we have suction, right? So we have attachments to the suction tubing.
The brush.
Right, so we're gonna have to brush their teeth, provide chlorhexidine oral mouth. How often? Every 2 hours. So if you're turning the patient every 2, you should be providing oral care every 2. All of these, the oral hygiene is part of the ventilator-associated pneumonia prevention bundle. All right, because again, going back to the airway, are we 100% sure this patient will not aspirate? No, as the cuff inflation pressure loses pressure, Can secretions go down? And are those secretions clean? No, they are dirty. Remember, we cannot reach these secretions here. So as long as we keep the mouth, because where did that secretion come from? The mouth. So as long as you keep the mouth clean every 2 hours, will the secretions be at least less dirty? Okay, so therefore that will help cut down on ventilator-associated pneumonia. Again, we cannot 100% prevent it. It's going to, inevitably happen, but we like to decrease the incidence, okay? Soften the blow. Extubation, when we get there. So obviously, is the patient still sedated when we extubate? When we remove the tube? So how do we ensure they can breathe if they're sedated? No more. That means, are they better or still pretty bad? They're better. That's why we're extubating, right? So we're weaning. We already did the weaning. So during weaning, that means they're off sedation. Okay, so we're doing breathing trials, okay, already. So we're seeing, okay, can they breathe on their own? Once they pass, then we do the extubation. So the patient here is awake. Then we tell them what to do. So we're going to tell them that we're going to quickly deflate the cuff. And right after deflation, it will just take 2 seconds. So when we deflate, we pull the tube out and then we tell the patient to cough like crazy, okay? Because can we keep the secretions here free for a long time? No, we do our best to suction it. However, remember, once we deflate this cuff, what will happen? Secretions will go in. So that's why we want the patient to cough. Okay, so you ready? So we'll deflate, pull, and then the patient should start coughing. And then we give the patient 100% oxygen. So they'll be coughing for a few minutes, and then eventually that should stop because now they can clear the airway. All right, so that's the extubation procedure. Yeah. So we won't do the remove tape. We no longer use tape. We will replace this with what? Remove the Velcro, right? Okay, and then deflate the cuff, pull the tube, give oxygen, blah, blah, blah. If the patient tolerates the extubation, good. But otherwise, you call the doctor if the patient has any complications, any difficulty breathing. You hear these like stridor, skin color change, mental alertness change. All right, so that means they did not tolerate the extubation at all. Keep them NPO just an hour or two, and then we restart the PO intake shortly after. Mouth care, of course. Any questions on the airway? So this is just the airway. We didn't do the mechanical ventilation yet. So let's finish the airway. So here's the high-low evac tube I mentioned earlier. Oh, no, this is a double cuff tracheostomy. Let me show you a high-low evac tube. So here it is. So you clearly have two here. So this lumen is for the cuff. So this is for the cuff, and this is for the suction. So you connect this to suction, and it'll allow you to suction this subglottal area here. We call it the subglottal area, meaning under the glottis. Okay, so this area here will be suctioned when you attach a tube here. And obviously, this is the pilot balloon used to inflate the cuff. Any question? As you can see, it's more expensive. Look at that. $400 for this piece of plastic. We should make our own. Kurt? Go into business?
Like, that's a good idea. Conscious.
You know how many patients are intubated in the hospital? That's $400 a pop. Right, complications from a plastic airway. Can it cause inflammation of the airway? Okay, so therefore, can the tracheal diameter change from time to time? Can it dilate? Can it also constrict? Yes, so inflammation of the trachea can cause bronchoconstriction, while dilation requires a higher inflation pressure. And these are the complications. So we've got accidental decannulation. When we have accidental decannulation, meaning remember when we do the trach care, what do we do with the ties again? With the old ties? We do trach care. Yeah, so when we replace it, what do? We remove the old ties and then put on new ones. What's the... No, you forgot already? Leave the old ties on and then put on new ones, okay, before you remove the old ties. Why is that done? To prevent accidental decannulation. All right? And here's your care for the patients with an artificial airway. Suctioning procedure, best practice. You should know this already. We've done the procedure. What do we do before you suction?
You give high pressure oxygen.
Hyperventilate, very good. Or hyperoxygenate the patient. Why do we need to do that?
You have excessive oxygen inside.
All right, because what will the suctioning do?
Oxygen.
It will cause hypoxia. Because are you only suctioning secretions?
So,
You are also suctioning air out of the patient's lungs. So we know about cuff inflation pressure. You should know about suctioning procedure, best practice. Okay, we'll continue with